Merci Nicolas. C'est un plaisir et un honneur d'introduire aujourd'hui cette journée dédiée à la déformation de l'adulte et de l'enfant, qui se veut un peu l'héritier du GES, maintenant très bien intégré à la SFCR, que je remercie. Donc, je présente maintenant le professeur Muharrem Yazici de Ankara, qui est un éminent chirurgien de la déformation pédiatrique. Il a un parcours assez exceptionnel. Il est maintenant le directeur du centre pour l'orthopédie pédiatrique et le rachis à Ankara, en Turquie. Il s'est formé aux États-Unis, au Kansas, avec le professeur Mark Asher. Il a été professeur à la faculté de médecine d'Ankara pendant une vingtaine d'années. Il a été très actif dans les sociétés savantes, président de la société turque d'orthopédie pédiatrique, président de la société européenne d'orthopédie pédiatrique et surtout président de la SRS, de la société de recherche en scoliose de 2020 à 2021, l'un des premiers à avoir ce poste pour un non-américain. Il a publié plus de 100 articles, surtout dans le domaine de la scoliose neurologique et des montages de croissance. Professeur Yazici, the floor is yours. Bon, désolé, je ne vais pas présenter en anglais. Mon français n'est pas terrible, mais mon anglais est encore pire. Donc, vous pouvez applaudir notre intervenant.
Thank you. Good morning. First of all, I'm very honored and proud to be here today as an invited speaker of French Spinal Surgery Society and have been granted the honor of opening the Congress. I would like to express my sincere gratitude to Congress Organizing Committee for giving me this opportunity. I've been asked to prepare a talk of my journey from periphery of Europe to the SRS Summit and the time allotted me. And I'm also grateful to Program Committee for leaving me free to determine the content of my speech. Nothing to disclose. Before I start my talk, I would like to summarize how I plan next 45-50 minutes. First of all, I'll briefly touch upon the concepts of Europe's periphery and the Turkey's place, where I come from in this context. And I'll talk about the structure of SRS and its founding principles and evolution of these principles over the time and summarize the factors that facilitate or complicate my journey to the top. Afterwards, I'll make presentation about my personal research on two basic research topics to illustrate how I overcame these barriers and to provide guidance especially to my young colleagues who have such goals. As you know, I come from Turkey, and the title given to me, Turkey was called the periphery of Europe. It's true. But if we consider Europe as a continent, Turkey is closer to mainland than Ireland and Cyprus. At least it traces part of my country, natural part of the European continent. And since this definition is not used for Scandinavian countries, this must be a political and maybe developmental structure of the countries. It's okay. It's not possible to object to this definition for 21st century. However, if we need to take a brief look at the history of geography I come from, I was born, I received all my education, most of my education, completed my professional formation in the lands where civilization was born and developed for thousands of years, and I acquired all the achievements that brought me to this podium today. I also recently came across some fun information about core and periphery. I have no idea how the calculation is made. After some sophisticated calculations, a physicist and engineer determined the center of the world to be a point 200 kilometers away from the city where I live. In 2016, Google Maps shared this information with its followers. I wanted to share with you as a nice example that the concepts of center and periphery are relative concepts and can change depending on how you look at it. I don't know how accurate this calculation is, but one thing that it's definitely true that Anatolia has been the bridge between the Asia and Africa all the history. Also, being a center is not always a good thing. 21st century, Turkey is located right in the center of the Ring of Fire. You can imagine it is to stay calm when you are, how difficult it is to stay calm when you are surrounded by fire on all sides. After this short historical political introduction about the first part of my speech title, I would like to say a few things about the second part of the title. SRS is a society, is an American society founded by 37 members in 1966. Having undergone great development and transformation over the years, today it's a society that claims global leadership in the fields of spinal deformity, education, research, advocacy, and lives up to this claim. In 2024, SRS is a brand with many features, and it is an organization that is accepted as a North Star by the deformity world. Its actions are carefully monitored and watched, its words are taken seriously, and its suggestions are meticulously implemented. Today, SRS has more than 1,600 members from 68 countries. Although there is still American dominance in general, the membership, if you look the young and candidate membership, and the non-American members will take the dominance in the future. This is also proof that the global leadership in terms of membership will be realized in the near future. The number of neurosurgeons and researchers in the society, which was founded by orthopedic surgeons at the beginning, also increasing rapidly. This process essentially started with the bylaw change or amendment 2010, which allowed the OUS, outside of US members, to become active members to society. SRS is an organization with a very bright record in terms of diversity. By electing an African American, Iranian American, African, Copt Egyptian the president far before long before the 2010. But all these presidents were practicing in United States. And the first all-US president was Ken Chang. It's been elected in 2017. I followed him. And after me, SRS's sensitivity to diversity continued, and we had a neurosurgeon president and female president. Now, Marinus de Kluver from Holland is sitting this chair as a third international or OUS president. My personal journey to top of the SRS started as a corresponding members in 1996. I was selected as the second international traveling fellows in 2002. And I was the third OUS member to chair a committee and the sixth OUS member to be elected to the board I was the first OUS program committee chair, which is one of the most important committee in 2018, and also I deemed worthy to enter the presidential line in 2018, and I became second OUS president of SRS. Since 1995, when I made my first presentation on the podium, I missed only one Congress. I think this is the most important slides that summarize this journey. I presented my research on the podium 27 times in the last 28 years at the Congress. As you know, it's a very selective selection of abstracts, and acceptance rates don't exceed 8 to 9%. I had so many poster presentations as well. I didn't do any of these alone. Academically, I may be one of the luckiest person in the world. I set out and with an excellent team, my two friends with whom I specialized together, and we founded the Hacettepe Spine Unit under the leadership of late Professor Surat, were my biggest source of motivation in the beginning. Ahmet Alanay is current president of Eurospine, and Emre Akaroglu was the previous president of Eurospine Worldwide Education Committee. Afterwards, I had an excellent fellows and partners, and I still work with an extraordinarily hardworking, talented, and productive team. Personally, I can say that I had an invaluable preparation period before reaching the summit. After a leadership position in the National Association, the presidency of European Pediatric Orthopedic Society in 2012 was an extraordinary contribution to developing my leadership skills. As you will appreciate, this journey was not easy or smooth. I had to overcome many barriers throughout the process, such as language, educational background, cultural, ethnic, geographical, political, and religious. If my younger colleagues are wondering how I overcame so many barriers, I can give them some keywords that can guide them on their own journey. Passion, dedication, hard work, altruism, teamwork, networking, curiosity, participating research, to present them in the meetings and publish them in the prestigious journal, but most importantly, consistency. Above all these, I think most important message would be that it is necessary to choose one or few basic research areas at the beginning of your academic career and concentrate on this area without distracting attention and energy. I would like to end the introduction here and now exemplify this issue of academic interest concentration with a concrete presentation. In the early 2000s, I chose early onset scoliosis as a main area of interest, and I started a prospective series of studies by evaluating gaps in the literature, especially regarding surgical treatment. I'll continue my presentation with a brief summary of these studies. Growing roads applications, I just started a group of experimental researchers in 2005 and using the immature pigs. all this study is done in another university because it has a very great animal research facility. And the results of all these animal research has been published in either Spine and JPO and also presented on the SRS podium. My focus of interest is mainly applicability of pedicle screw in growing spine, effect of pedicle screw on growth, effect of anterior fusion on growth, and pedicle screw and growth modulation. The spinal instrumentation and the fusion in young children. This title is something weird for the young generation because the spinal instrumentation, even in the infants, is very standard procedure today, but not far. Just 20 years ago, this wasn't a crazy idea. We, as a spine surgeon, mainly prefer either in situ fusion, or if we need some instrumentation, we limited our instrumentation inventory only with hook. The pedicle screw instrumentation, of course, is a revolutionary development in spinal surgery. It's giving the strong vertebral purchase, improved control of instrumented segments, rigid immobilization, and the greater correction of spinal deformity. Pedicle screw in the pediatric group is being used first in tumor and trauma cases, first in adults and in adolescents, lately, very lately, for young children. Pedicle screw in young age, I started to use them in the early 2000s, mainly for lumbar spine on the growing growth technique or hemivertebrectomy or some other metabolic disease. But since the beginning, I had some unsolved questions in my mind. First one is the three major problems. First one is dimensional matching. Second one, the growth arrest is causing by neuroarterial cartilage damage. And finally, insufficient bony purchase because of cartilaginous nature of the pediatric or immature child's vertebrae. This is the first study in this field we made. We just did a CT study to understand the pedicle diameter in the pediatric age group. And this was a little bit discouraging because, especially in the L1, the inner diameter of the pedicle was 2.3 millimeter. It's very, very thin. How can we put the proper size screw inside of such a small and thin pedicle channel? There's two options. We can decrease implant size. Okay, it's theoretically possible, but practically, I think it's not realistic because inferior biomechanics. Extrapedicular screw instrument insertion, we know from the adolescent literature, sometimes, time by time, we use in-out-in screw as a salvage, but we don't know the safety and reliability of this technique in young children. And third option, it's a brilliant idea to increase the pedicle size. As a pediatric orthopedic surgeons, we well know the biologic plasticity of the pediatric bones. If we can expand the pedicle, and can we accommodate a larger screw into it? And if it is possible, how it works biomechanically. At that time, there was no information in the literature about this, just one in the SRS presentation by Tony Rinella. He didn't publish after that. It's a 9-year-old cadaver. He just showed some capability of the enlargement of the pedicle using a serial dilator. The first study in the cage site, we just analyzed the pedicle expansion and on the pedicle morphology and biomechanical stability in immature pigs. We developed some special dilators, And finally, we showed that pedicles of immature spine can be expanded through serial dilations with dilator, but this process significantly decreases the pull-out strength of the pedicle. Second part of the study is an in vivo setup. We just using the same technique, but the animals were sacrificed after the third month. In this study, we found that both expanded and the control group's pedicle pull-out strengths reached the same level. It means biomechanical stability of the screws at the expanded and non-expanded pedicles is the same after 3 months. The remodeling capacity of pedicles and overgrowth bone on screws may have an effect on this result. In other topics of my interest, growth retardation. We know the effect of metallic implants on the physis. It depends on type of implants and smoothness or threaded fashion, and also percent occupancy of the physis. This study, it's also the focus on the effect of pedicle screw placement with or without compression across the neurocentral cartilage on the morphology on the spinal canal in pedicle and immature pigs. For this purpose, I designed a very specific screw, some threaded part, some smooth part. We are aiming to locate a smooth part in neurocentral cartilage, and also with the simple knot, we just add it, and we are aiming to apply some indirect compression with this knot. End of the study, we showed that both compressed and uncompressed pedicle screw application end up with narrow hemicanal and short pedicle. This is something worrying. It means in early ages, using the pedicle screw instrumentation can cause inherent risk of atherogenic spinal canal stenosis. However, later on, we just check our group of patients who underwent the hemivertebrectomy in early ages by CT scan in longer follow-up. Luckily, we didn't see such a significant side effect and in terms of canal development and the pedicle elongation. How can we explain this? The simple thing, at the age of 5, the vertebral canal is already reached in the adult size in children. After the procedure, after the age of 5, even pedicle screw instrumentation, it's very safe in terms of pedicle screw instrumentation. Another topic. When I saw this picture in the first, it's the typical Klippel-Feil syndrome, I saw the AP diameter of the congenitally fused vertebrae is significantly shorter than the upper and the lower vertebrae. I did not explain why. And then I also observed some similar effect of my hemivertebrectomy cases. After getting refusion, 360-degree fusion, I saw my AP diameter of the instrumented area is significantly shorter than neighboring segments. Then, this was the idea. Neurocentral cartilage, as you know, has a bipolar growth during the growth period, and the neurocentral cartilage also moves backward when child grows. If we stop this movement, this positional change on the space, maybe we can create some vertebral body growth retardation. This is another the PIC study to analyze the effect of anterior spinal fusion on spinal canal development in immature porcine model. We perform 2 levels anterior discectomy and the anterior instrumentation, and we didn't do anything from back. At the end, of course, we create some kyphosis, but also AP diameter of the vertebral body is also shorter than adjacent segments. Also, this explains why we see the narrow vertebral body in the Klippel-Feil syndrome, because neurocentral cartilage is not responsible only for the development of vertebral canal, but also vertebral body as well. Jumping in other topics, still stay in the growing spine. The spontaneous ankylosis or fusion, and every surgeon dealing with the early onset scoliosis has been faced this problem. And at the time of the graduation, you have to make as a big osteotomies. But I've seen very bad fusion in some cases, but in some cases, the spine, even after the multiple distraction, still stay very mobile. Of course, some scar formation, but not fully fused. And this is the next study to understand the effects of fusionless instrumentation on the discs and facet joints of unfused segments as a pig model. This is the same model again. One group is instrumented fusion, another model is growing rod simulation. And the end of the study, instrumented fusion group, discs were 10, facet joints were degenerated, hypertrophic zone is being destroyed. But the growing rod, some changes, but very similar to the control group. It means with the growing rods, of course in this group of pigs, we just elongated 3 times. It's not exactly simulate our clinical practice, and our kids is being distracted 10 times, sometimes more. But growing rod itself, it's not causing disc degeneration or facet joint arthritis itself. It has there have to be some other factors like surgical errors or infection or misplacement of the screws. The next topic is, and also next idea came to my mind when I see this picture, one of my growing rod patients. As you see, before the index surgery and almost 4 or 5 years after the index surgery, you see this is the L4, L3, and this is the L3. The L3 vertebral body height is significantly longer than the other segments, and also comparing the pre-index levels. And as we pediatric orthopedic surgeons, we are aware of Hütter-Volkmann law very well. If we apply some distraction over the physis, you can stimulate the bone growth. Is it true for vertebrae? This is a study to understand the effect of distraction on the growing spine. We had a group of patients and they simulated the growing growth and distracted regularly, and finally we found that distracted segments vertebral height is significantly longer than the other segments. The conclusion is continuous distraction of the vertebrae also increased the vertebral height. Also, this is proven by a clinical study after that. This picture I was taken from the literature is about the PJK. PJK, it's very is hotly debated issue in the growing growth literature. It's seen very significantly. Personally, I didn't see too much because I'm following some strict surgical principles and rules, but the next topics to understand the PJK or PJF is a fate of distraction system or growing growth, or it's somehow preventable. This is again is in the same model, to understand the effect of fusionless instrumentation on the adjacent segments. We use some sophisticated machine to check the motion and instability, and also we analyze the segments histologically, and the growing growth, it's closer to normal physiology even after several lengthening procedure. I cannot say the growing growth is safe in terms of PJK, but the PJK is seen after the growing growth mainly caused by our technical error. It's not the fate of procedure. The last topic I would like to briefly touch in the convex growth arrest. And the convex growth arrest isn't a technique, it's a very old technique. It's been performed many times in our centers, our predecessors. We have a very extensive experience with this. We had a very, very good results in some patients, but in some, the results were significantly worse and bad. Its results are unpredictable. Again, the pedicle screw, the passing through the neurocentral cartilage, is the holding anterior, middle, and the posterior column, can control the vertebral growth, as we know from the Mark Asher's puppy studies. And the classical convex growth arrest fuse spine from back and front. How can we eliminate the anterior fusion, and how can make our fusion more stable and strong? In this context, we just put the pedicle screw in the convex epiphysiodesis area and only fuse the spine from the back. We just started to use this technique many years ago. Some very good promising results we got, and I'm still personally using in some selective cases. But this application started not having any scientific evidence in our hands. That's why I just created another animal study just to simulate this technique. And finally, we found that the posterior instrumented hemiepiphysiodesis is effective as anterior posterior convex epiphysiodesis. If you are interested to perform to only a convex side fusion, you don't need to go anterior. You can do everything from back with the help of pedicle screw instrumentation. At the end of this part of my speech, as you see, animal studies in growing spine research cannot be automatically extrapolated to human studies, but provide good and strong evidence. It is possible to find answers to your many questions encountered in the bedside from the cage. As long as you follow these questions with patience and persistence, I believe you can find some good answers. Probably this is the group of bundle of the research. It was a good example how I just concentrate on some topic and persistently concentrate on one research and one topics, and helps me to bring up to summit. Another interesting topic to me, I choose another research area in the 2010s and later, the long-term and the non-spine effect of growth-friendly techniques. I'm calling them as a hidden cost of growth-friendly treatment for early onset scoliosis. The question is, do we more harm than good? EOS, as you know, is a spinal deformity, begin before the age of 10, regardless of etiology. Its natural history is life-threatening. A growth-friendly treatment in general terms, it means the continuous management until skeletal maturity, oftentimes longer, usually requires repetitive intervention because of nature of the procedure or complications that develop during the treatment period. The goals of growth-friendly treatment is to correct deformity, maintain correction, and preservation of growth potential of both spine and thorax. These are objectives I listed here. With the growth-friendly techniques, regardless, growing growth, spring distraction, MCGR, ulcer, Webster, all these techniques, deformity correction should correct the deformity and maintain over the years, should get normal trunk height and this proportion between upper and lower bodies. Thoracic height and lung development should be normal. We shouldn't cause any harmful effects of structure and function of the spine. Complications should be, and requiring unplanned return to OR should be minimum. We have to reach a minimum pulmonary capacity as high as possible, and the HRQL should be close to normal. And also, getting all this benefit, we shouldn't cause any negative impact on the patient's mental and behavioral development, and our systemic side effect should be minimum. I just put this rectangle here because in the next 10 minutes, I'm going to concentrate on this non-spine effect of current growing growth techniques. Questions. First of all these objectives are doable. Second, are current techniques, available techniques, is effective to reach this goal? And most importantly, are we incurring some extra or hidden costs to meet these objectives? This is one of the best examples from my series. I saw this patient when he was in the 1965 and 15. At that time, he was in the age of 3. After in the 9 years, is a 2 MCGR exchange. Finally, last year, I graduated with the posterior instrumentation and fusion. During this journey, he had 1 index, 2 exchange surgery, and 1 graduation surgery. Only 4 surgeries. It's no complication, no unplanned return, very nice correction in coronal. A reasonable correction is not perfect, but a reasonable correction in the sagittal, and it's done. Also, in the other patients, in terms of deformity correction, we were successful. It's almost full correction in coronal and sagittal. Of course, very commonly we see in the growing growth patients, she developed some adding on deformity during the process, but doing some PCOs and some extending instrumentation, we get nice 3-dimensional correction after 13 years. In some cases, adding on deformities are bigger than to control with the PCOs. In those cases, we simply perform the tricolum osteotomy, either PSO or the VCR. Again, we can get nice coronal and the sagittal balance. In terms of deformity correction with the growing rod technique, I'm mostly talking about the growing rod because I do mostly growing rods. And we can say the growing rod technique in terms of deformity correction is very successful. After all these efforts, we can get very good height gain in terms of T1, S1, T1, T12, especially idiopathic or idiopathic-like deformities. Congenital or syndromic, I think, should be considered differently. Again, in terms of thoracic height, if the surgery is not complicated, if the patient doesn't have too much rib fusion or chest cage abnormality, the thoracic height, T1, T12 height, easily reach up over the 21 centimeters, which is critical for normal pulmonary function. Also, in terms of functions of the spine, many of my patients, idiopathic patients, after the growing rod, during and after the growing rod treatment, participating in the daily activities, some of them even doing very aggressive sports like, heavy lifting or, bodybuilding. Complication, of course, inevitable. This is one of the classical paper. It shows is about 58% of the patients have developed minimum one complication. But I would like to remind you, this is very heterogeneous group in the multicentric study, and most of them require the unplanned return to OR. Most of them are inevitable. Honestly, I believe you can share the same feeling with me. The single centers and single surgeon series is a very well controlled series. The complication rate is not such an high, but the procedure is open for complication. Even you prefer the magnetically controlled growing rods. This is the first MCGR graduation paper in the literature. The overall complication rate in this cohort, again, is a multicentric. Jean-Luc Jouvet and Sébastien Pessanti, I don't know if they are here or not, also is a part of this study. About 40%. But again, these mostly are manageable. But in terms of deformity control, in terms of trunk height, in terms of thoracic cavity development, growing rod looks like as an effective method. But all these are bright side of the moon. But we have the dark side of the moon as well. In the past, the surgeons dealing with the early onset scoliosis in particular, spine surgeon in general, when they are looking in the X-ray, when they're analyzing the X-ray, just only concentrate on the middle of the frame. But this frame has been widened by Bob Campbell when he described the thoracic insufficiency syndrome. Now, we are questioning the areas towards which we used to turn a blind eye in the past, like pulmonary, psychosocial, neurocognitive development, and iatrogenic issues like metallosis, radiation exposure, etc. And as a surgeon, our responsibility is to take every possible action to prevent iatrogenic damage to the patient's general health and to improve their quality of life. This is the point I've taken in 2010, and also I concentrated on my research in this particular field, and I just planned many prospective study is to find some answer all these questions. Again, another persistence of one of the research topics. Let's look about the spinal alignment. Sagittal alignment of the spine, as you know, is evolved during old age. We are in France, and we are the guru of the sagittal alignment. I'm not person capable to speak about the sagittal plane in front of the French Spine Society, but we performed in this study many years ago to understand the evolution of sagittal segmental alignment of the spine during the childhood. This is the normal development. Also, PI increasing by age and constant after the maturity. But in this growing rod treatment, we just fixed the sagittal plane with the instrumentation in early age. Even we are not performing the fusion, but we are fixing the sagittal plane, not allowed to evolution. This would be an interesting topic to discuss, especially long instrumentation, including the thoracolumbar spine, may cause some retardation of natural development. And in this study, we documented in the growing rod patients, our patients have lower thoracolumbar kyphosis and less pelvic incidence. This is side effect, but we don't know exactly the long-term effect of this side effect. The second point is pulmonary. Longitudinal growth of the spinal column is very important for normal pulmonary functions. The enlargement of thoracic cage and it allows increased space for the lungs to develop. And that's why the thoracic cage can be referred as the fourth dimension of the spine. If the deformity is progressive in this age group or progression is not prevented, it can end up with chronic pulmonary disease, severe cardiorespiratory failure, or even early mortality if left untreated. Early fusion is not a good option, it's not a good solution, as Caroline Goldberg shown many years ago. Early spinal fusion is unacceptably high cost to the patient. The effect of growth-friendly techniques on pulmonary development has been extensively studied in the literature. Most of the papers are coming from the expansion thoracoplasty worlds. And in these papers, with the Webster treatment, forced vital capacity can increase a little bit, but percent predicted values didn't change significantly. All these studies consistently showed the same results. FVC can increase, but percent predicted values is not improved with our surgery. How about the growing growth? One paper in the literature from China, it showed some FEV1 increase and FVC1 increase over the years, but the differences are not significant. We designed a study just only looking for growing rod graduates with idiopathic early onset scoliosis and compare our graduates with AIS and healthy instrumented fused AIS and healthy subjects. At the end, we use some sophisticated technique. We analyze exercise tolerance, oxygen consumption, breathing reserve index. All these parameters were comparable between the growing rod and AIS, but growing rod still less than growing rod graduates, even idiopathic etiology, less than normal peers. Expansion thoracoplasty has also another significant problem. And because the rod is bypassing in the chest cage, at the end of the process, chest wall compliance decreases significantly. This is also very, very bad things for long-term pulmonary function. How about the psychosocial health? This is the issues came to our interest first by Jack Flynn from Children's Hospital of Philadelphia. And he published in the first paper in JPO, and looked on the 12 vector patients, analyzed some psychosocial tools with the psychosocial tools. He reported almost 60% of the children had abnormal results at least one scale, especially if the treatment started early. The following study from same group also documented as the number of the surgeries increases, the psychological side effects also increases. We did perform in the first study in this field in the 2016. We just analyzed our group of growing rod patients with very, very extensive psychological, psychosocial evaluation. It's worrying thing, depression symptoms and anxiety in our group of growing rod patients very significantly higher than the normal population. But the good news, increasing number of the surgery, both anxiety tended to decrease because the patient's kids can develop some resilience or some coping skills, and also emotional functioning and psychosocial health summary is being better. And the second study in this line, we just compare the MCGR and the TGR. Our hypothesis was MCGR as the less invasive procedure, less surgery would be better for kids' psychological health, but unfortunately, MCGR patients didn't show a significant difference in terms of psychosocial characteristics. And finally, these two papers, these two studies were done for the patients, the treatment still undergone. And finally, we just look only for our graduates. And we just analyze our idiopathic or idiopathic-like graduates. And again, it's very worrying results. 8 of our patients had abnormal ratings in last one of the scales evaluating psychopathology, and psychosocial impairment of patients may be more prolonged than the period of repetitive surgery and possibly even lifelong. This is also very, very worrying message to us. How about the quality of life? Quality of life in covering both physical and mental well-being of patients. This is one of the first study in the literature to analyze the patient's quality of life using EOSQ, and both MCGR and the TGR patients had some some problems in terms of the HRQL scores. And also, there is no significant difference between magnetically or traditionally lengthening growing rod. This observation is being confirmed by Matsumoto later. Very new study just published in this week in JPO, and the EOSQ is based on parents' report, parents' feeling, because the kids in the early ages are not capable to fill this questionnaire. The new questionnaire developed by Vitali group, they called as EOSQ Self, is being filled by patients themselves. We just compare the EOSQ. It's being filled by the parents when the child was 3, 4, 5 years old, and we just gave the EOSQ Self after they became mature. And then we found significant differences in terms of many domains. Of course, this evaluation is done in the 2 different time frames, but the most important message, and the kids' answers are usually worse than the parents' answers, experience their condition probably worse than their patient's perception. Also, we have to keep in mind in this issue. Another issue is metal ion release. Metallosis is not new. It's very commonly discussed issue in the arthroplasty literature, especially metal on metal implants, but also extensively discussed in the spine literature for AIS. Any surgeon in this room is performed in the MCGR, I'm sure, has faced this picture, is the black staining area just behind of the magnetically controlled growing growth, and also pathologic specimen you see, and all the metal ions is phagocytized into the cells. There is no doubt that some metallosis, especially surrounding of the MCGR, is seen. But we didn't know the levels of this metal ions, and also we didn't have any idea about the difference between TGR and the MCGR. This is the first study in the literature. We just look at the metal ion release in patients surgically treated EOS, TGR, MCGR, and non-operated controls. MCGR groups of elevated levels of vanadium and titanium and aluminum. At this moment, we don't know exactly the long-term effects of this metal ion release or accumulation, but in practically, we are taken out in all the MCGR when we finish our procedure. Our growing growth procedure is completed. One of the final issues about the radiation exposure. Imaging for scoliosis has been linked to an increased mortality from breast cancer, endometrial cancer incidence, and even inferior reproductive outcomes. There are some reports showing increased breast cancer in the previously treated scoliosis female. With the current imaging techniques like EOS, the overall radiation exposure significantly decreased, but still radiation is radiation. This is a study done by Greg Mendes from San Diego, the surgically treated EOS with the standard spine radiographs. He documented estimated calculations 3.4 times more ionizing radiation when compared to estimated background radiation. Of course, if the patient needs revision, exposure needs to be higher. This is a big issue and also putting out a big responsibility as a spine surgeon, as the surgeon dealing with the early onset scoliosis. Final topics of the neurocognitive development. FDA released a warning in 2016 and to repeated or lengthy use of GA and sedation drugs during the surgery procedures in children younger than 3, in pregnant women during their third trimester may affect the development of children's brains. The mechanism is not clear, but possibly neurotoxicity, inflammation, increased oxidative stress, cerebral perfusion abnormalities, and maybe loss of autoregulation. 3 prospective studies initiated in the United States and then published in just a few years ago. Good news, after the 3 years of age and only single exposure is not risky for brain or cognitive development, but still we have to be careful. From the EOS perspective, in our practice, we start early on at growth-friendly techniques, usually after the age of 5 or 6. We don't need to be worried too much. But for the patients undergoing to casting under the GA, I think we have to review, we have to revise our protocol to reduce or eliminate repetitive anesthetic exposure for young children. Today, after seeing all these side effects or some extra cost, there is another discussion. Tweeners, personally, I didn't know this words till 4 or 5 years ago. This is the mainly sports words, sports terminology, but came into our vocabulary in the last 4 or 5 years, is describing if the patient is not good for fusion, is not good for fusionless surgery, just in the middle. This is the patient from my personal series, 3 patients. These deformities are similar, is about on the age of 10 or 11. I treated first one with the growing growth and the multiple distraction and the graduation. This one treated by posterior instrumented infusion, just 1 step. And the overall deformity correction, it's definitely better in the fusion surgery, and also height gain was not bad. That's why in the age of 10, after the age of 10 in girls and age of 11 or 12 in the boys, probably growing growth is not really good. Growth-friendly technique is not good idea. Just simply jump to posterior instrumented fusion. However, reviewing all these side effects or hidden costs of the growth-friendly technique, I would like to ask you, if tomorrow or next week, in Monday, in your outpatient clinic, if you see this patient, 6-year-old, treated with the brace, but the brace is not effective, or the patients are not compliant to use brace, and the deformity is documented, progression is documented, how can we do? To me, the answer is still growth-friendly technique because of age, because of their growth potential. As a conclusion of this part of my speech, and scoliosis may be a musculoskeletal deformity, but early onset scoliosis is definitely a systemic disease. Spinal deformity is just the tip of the iceberg. Both treatment and the disease itself have the capacity to affect the child's health in many different ways. Growth-friendly techniques prevent cardiopulmonary disease, but surgical stress brings a psychosocial burden and may persist into adulthood. Persistently elevated levels of metal ions, especially growing system, like a moving system, is open to friction, is a still serious concern. We don't know we don't know the long-term effect. It's unclear, and also, despite the new technology, increased radiation exposure in patients with EOS is still an issue. The outcomes can be successful by means of deformity correction, but as a surgeon, as a researcher, as a scientist, as a father or mother, we must look at a wider perspective as the systemic disease deserves, because we are dealing with the child. They have a potential to live in 60, 70 years after this procedure or treatment. By the end of the treatment, we may have a straighter spine, but this seems to come at hidden cost. We shouldn't forget this. I would like to end my speech and one of the famous Winston Churchill's quote to make an analogy. This is the best until we will make the better one. I'm just finishing to show one of the first slides with you, especially to young colleagues. I like to remind you to get in the step higher. You have to be passionate, you have to dedicate, you have to hard work, of course, but you have to be curious and to participate in research. If you have a dogged persistence, overcoming barriers is not difficult at all. Nothing is impossible. It just takes time and no reason to hesitate or give up. Thank you for giving me the opportunity. Thank you for your interest.
Thank you very much, Professor Yazici. It's a very outstanding lecture. Est-ce qu'il y a des questions dans la salle? Professeur Charles de Strasbourg.
Yeah, thank you very much, Mohamed, for this outstanding talk, giving really a big view on your career and also how non-US surgeons can move up and climb up the mountains, which is something which is very odd, probably in Turkey, but also in Europe all over. I also liked very much all your research and the large field of things that you presented. Actually, I have two questions. One is maybe, as you said, it's very difficult to address these early onset scoliosis, and we're facing more political and economical issues all over Europe and within the world. It's one of the topics of SRS and Eurospine as well, which is the medical device regulation issue. How do you handle these difficult issues, especially with regard to this type of treatment in Turkey? What's your vision on that?
At the beginning, I mean, till the last 10, 15 years, we had all the implants available in the US and in Europe. Also, that was available in Turkey. We were using pediatric screws and the pediatric device like Vector or the growing rod. But now, many of the international companies left the countries. We cannot reach some of the fancy or new developed implants. But the problem is today, the implant, it's issue, but it's not a big issue. The problem is in the philosophy. First of all type of the implants which is used for growing rods, at the end of the day, will lead some growth retardation. That's why our main focus would be stay in the non-operative site as much as we can. And the other legal, technical, marketing issues, some way we can find to solve them, overcome them. But the problem is, even you have a fantastic, modern, well-developed, the sophisticated implant, I think we shouldn't be too aggressive to treat them with the implants. The early onset scoliosis is true for all patients, but maybe it's more than true for early onset scoliosis. I showed some picture. The spinal autofusion or iatrogenic spontaneous fusion is not fate, but even you perform a meticulous technique, if you are fixing the spine by rods, put some rods, no way. You can disturb the spinal health and growth capacity, and potentially you can lead some iatrogenic damage. In Turkey, Probably we are luckier than you because our regulations are not strict like yours, because I know it's in the new MDR regulation or other things. This is not significantly affect yet, but again, the metal issues or implant issue is just by side. But we, as a surgeon, we have to concentrate how can we manage our kids without surgery. Today, I believe we are still so far from the ideal treatment. I mean, as a spine surgeon, we are still doing some morbidity surgery. It's hard to say, but unfortunately, this is true. Just my feeling.
Thank you very much. So there's a long way to go.
Mm-hmm. Yeah, definitely.
D'autres questions dans la salle? Professeur Ferrero de Paris.
Thank you for your really great talk. I have just one question about your last slide and your last case. You show some fusion for 10, 11 years old. And I think this is a big issue to know when we can start to do the fusion. So what are your criteria in this young, almost mature patient to say that I am not going on a growth modulation technique, but I'm going on a fusion?
Okay, great questions, thank you. First of all, we have to differentiate in idiopathic and neuromuscular and congenital etiologies. And for congenital and neuromuscular etiologies, decision is easy because they already have lots of comorbidities. They have a very less growth expectation. That's why we can easily decide them to fuse spine to eliminate the risk of repetitive surgery. But the problem is for idiopathic, otherwise healthy patients. Just look back in the definition of the tweeners. Tweeners in the recent literature is defined as 10 to 11 years for girls, 11 to 12 years for the boys. Also, you can use some Sanders grading checking by hand X-ray. But these are giving you some insight, but patient should be evaluated differently. Some patients looks older, looks mature, and also, to me, one of the other criteria for selection of the definitive fusion is flexibility. Summarize all of these things. If the girls is the older than 10, 11, deformity size is about 60, 70, and less flexibility, I do posterior fusion. But if the patient still young, the age of 10 in girls, but looks very, very short, and also family, I'm just checking the mom and dad, both of them is very short, and showing some flexibility, I still do some growing growth technique. But other issues about the VBT. This is the very hot debate. Maybe you will discuss in this meeting later on. And I do VBT for lumbar spine as a hybrid, also hybrid version, but I'm personally not good believer for the VBT for thoracic spine because posterior instrumented fusion for thoracic spine, more predictable, almost 100% correction with less morbidity. That's why in this group of patients, if my patient's deformity size is bigger than 60, looks, I mean, pretty much reasonable to grown, and I definitely do posterior instrumented fusion instead of growth-friendly technique because it's timely, costly, exhausting, and leading many complications.
Thank you.
Well, I have one question. You mentioned psychosocial issues. I think that's a very big, very hot topic. And from my experience, I have problems when I announce the second surgery for EOS patients. So the first time, the parents understand usually the need for surgery. The second time, they have in mind the first one, and even though I say it's lighter, it's shorter, it's simpler, I am in trouble with this. Can you comment?
Yeah, definitely. I mean, in our first study, we showed a significant percentage of the psychological diagnosis at the beginning of procedure. When time goes, after the multiple, or not second, third, fourth, fifth, their psychological symptoms is being less and less and less. At the beginning, it was shocking because we were expecting higher and higher. But then, after the very, very long discussion with our psychological friends, psychiatric friends, we understand that, okay, both kids and the parents can understand the procedure are not difficult as they thought. It's not painful. They can easily go back to play and the school just day after, and they develop some coping skills. But anyway, the end of the treatment, their symptomatology significantly improve comparing the start and finish, but comparing these healthy peers, they still have some psychological symptoms. That's why we have to follow them. We have to inform the family for the future. Maybe they have to get some psychological support during or after finishing our treatment. Okay.
Thank you very much on behalf of the society.